automate payers. So I'm on the dark side of the equation, but I spent 16 years working on the provider side of the house as well, primarily for an electronic health record vendor, which is also probably the dark side if we kind of think of it. But what we're going to talk about today, it's been my experience having worked both the payer and provider side, that a lot of people have either worked one or the other, and very rarely have they worked both sides and get that perspective from the other side. So I have a counterpoint webinar that I do to payer audiences, like from the provider perspective, because it's very hard if you've only worked one side to understand everything that goes on your counterpoint side. So that's what we're going to talk about today. Just to run through the agenda, there's lots of problems in healthcare, right? But we're going to focus in on a specific problem that is really requiring these walls between payers and providers to kind of come down. We're also going to talk about the industry response. So as the Senior Director of Economics and Digital Health Strategy, I actually read the legislation and the regs. That's what I'm paid to do. I probably need therapy. It's, I've actually read the Affordable Care Act. I think I'm one of 2 or 3 people in the country who have actually done that. But anyway, it's easy to look at the federal level because those rules, those regs, those laws apply to everybody. But the reach of the federal government really pertains to Medicare, and specifically Medicare Parts A and B. So even when you get into privatized Medicare, Medicare Advantage, which is Part C, or even to some extent Part D, which is the pharmacy side, their reach, they have some control, but their reach isn't as broad. And then we get into the state level. So we're going to break that down a little bit and kind of just do kind of a state of the union and what the response has been there and some of the mega trends. And then we're going to talk about your claims. So this is the big thing that I'm going to ask you to do and hope that you walk away with today is when you think about your claims process, instead of thinking of it as a means of getting paid, which it is, I want you to have a mental shift where you begin to think about your claims as a reporting vehicle to the people who pay you. It always has been, and we're going to dive into that a little bit. And then I'm going to pull back the curtain and tell you how payers are using your claims data so that you have some idea, some perspective of what's going on the other side. So let's kick it off with just kind of outlining the problem that's going on. Now, when we think of our contracting to these various payers, there's a framework that's been developed, and think of your contracts this way. If I have a contract with a payer and it says that I agree to accept their fee schedule as payment in full for services rendered, and there's no other consideration, if I do a chest x-ray and there's a benefit that exists with this payer and I'm under contract, I get paid. That type of payment arrangement is a productivity model. I get paid every time I do something, but it's also transaction based. It's really only saying, did you do it? Is there a reason that you did it? And you answer those questions on a claim. And if so, we pay the benefit. Now, under the Medicare Access and CHIP Reauthorization Act, under MACRA, this whole thing, again, CMS, the thing they directly control is Medicare Parts A and B. So as of this next year, you will see no increases in the Medicare Part B fee schedule. That's the law. So short of literally an act of Congress, you're not going to see an increase in a traditional fee-for-service type of arrangement with Part B Medicare unless there is literally an act of Congress. So, so just be aware of that. So this is a dying breed because they want to move into value-based payment. And this is where your data, particularly your claims data, becomes very important. So my patient goes to the provider files claims with the payers. Now, what happens is your payer has systems and they have fee schedules. So even if I'm a payer that's limited to the boundaries of a state, I only operate in Michigan, or I only operate in Wisconsin, I may have multiple fee schedules because I operate multiple lines of business. I may have a separate fee schedule for a certain specialty as compared to another. There's lots of reasons for this. So your claims bump up against a fee schedule, and then they price those claims out, and then they send it to their core system, which is a claims administrative processing system. These systems were put in place in the mid-90s when HIPAA came out. HIPAA was the big game changer. It was, and if any of you have been in healthcare a long time, you probably remember doing paper claims. HIPAA was the thing that made everything electronic, right? And it said it had to be locked down, safe, secure. So that's when a lot of these payers went in and implemented their core claims administrative payment systems. And these systems still exist today. They're like Soviet mainframe 1990s technology. And the reason, and this is for most of your payers, and the reason that they don't replace those systems with more modern technology is because on average it's going to cost anywhere from $40 million to $200 million to rip and replace that baby. And it's also going to take about 3 years to implement. Not to mention what that could do to the payments that they need to administer for their live active business. So they're very reluctant to do that, but it hits that claims engine and then they cut a check to you. This is simplified. Of course, there's a lot of things that go into this and we all know this, but this is the traditional way that healthcare has economically been accommodated for a very, very long time. So what has that produced? Well, we didn't always have payers in the market, but they really started to hit in the around 1929. That's when in Texas, the Texas Hospital Association got together with the teachers union and they said, "Ooh, let's prepay for healthcare." And for $7 a year in Texas in 1929, you could get up to 21 days in any Texas hospital paid for in full. I don't think you can get a Tylenol pill in a hospital for $7, today. That progressed, and by the time we got to 1965, 23% of Americans did not have hospital coverage. So that's a familiar problem that we have in the U.S. So there was a law signed by President Johnson, created 2 new titles to the Social Security Act, and created our 2 entitlement programs to take care of the elderly and the poor. And yes, you can be both. You can be old and poor, right? At the time that these programs were created, we didn't live that long. So we lived to about 68 years. You become Medicare eligible at 65. So that's when, the government's going to carry water on you for about 3 years. So when we look at the population that was on these government programs, it was a pretty small percent of our U.S. population. Also, if we look at the cost of healthcare in 1965 as a percent of the gross domestic product. Now, the way that you kind of think about this is if I spend $1 in the U.S., how much of that dollar goes to housing or transportation, or in this case, healthcare? In 1965, 5.6 cents of every single dollar spent was spent on something healthcare related. So this is kind of where we are today. There's always around a 2-year lag. They publish these stats at CMS in December. So we're almost ready for our next update for 2018. But as of 2017, when we look at the population that was on a government-sponsored program, so when I say Medicare, I'm also including privatized Medicare. So that's Part C. And when I say Medicaid, I'm also including in that privatized Medicaid. And we've got that going on many of your states, where your Medicaid agency has contracted with a private entity Those arrangements in privatized government-sponsored coverage are capitated. They pay that plan, excuse me, they pay that plan a flat dollar amount for that person based on their health status, and that's all the money there is. So that's how the plans get paid. When we look at the population that was on a government, where the dollars were coming from a government entity, government-sponsored coverage, quite an increase. The other thing is when we look at the percent of our spending that goes to healthcare, we actually ran over 18% in 2018. I think it hit 18.1%. We'll see those stats pretty soon. But we're spending almost 18 cents of every single dollar we spend in the U.S. is spent on something that's healthcare related. So that could be Band-Aids, insurance premium, co-pays, it's everything, right? And that's a lot of money. When we compare ourselves to other industrialized nations like England or Canada or Germany, that number, and they have longer life expectancies and lower infant mortality rates than we do, that number should be around 10.5%. So that's a lot of money. And the projection is just insane. So if we look at this across the 54 years, the other thing that I would point out to you is the increase of coverage on government-sponsored types of plans. So very, very soon, every other person walking through your clinic is going to be covered by some type of government-sponsored program. That's where we're headed as a country. So just kind of be aware of that. So that's what Category 1 reimbursement has produced. So what's the answer? Well, they're all trying to get into value-based payment. Instead of just paying for a chest x-ray, I want to know that that chest x-ray had a positive impact on the patient's outcome or their health status. So I'm going to get away from just flat out paying because you did something, and I'm going to start to look at data. I'm going to look at the analytics. So a Category 2 contractual arrangement with a payer that's where I get an incentive for like putting infrastructure in, like the medical home, or for performance, on my well child visits or flu shots or something along those lines. So it's a bonus. This is also the merit-based incentive payment system under MACRA, where I pay differentially. I pay Dr. Jones and Dr. Smith $5 each today for that service. And then I look at the data and I see that Dr. Smith his data shows he's a high quality provider with low costs, and Dr. Jones is showing as a low quality provider with high costs. So I'm going to take $2 back from Dr. Jones and I'm going to give it to Dr. Smith. So Dr. Smith nets 7, Dr. Jones nets 3. That's MIPS. That's a Category 2 payment arrangement, and it's driven by data. Categories 3 and 4 is where we start to pay across the ecosystem. So what that means is the patient goes to the provider who is part of a community of providers. So think about your affiliate clinicians with whom you share patients. Where do you refer patients? Who do you get referrals from? What hospitals are you associated with? So that patient goes to one of those providers, but they're also being attributed an entire population of patients. And they're being told, even if it's not a formal ACO, you're responsible for the costs and the quality of care for this population of patients. So this could be a patient that doesn't even come in and see you. So those providers are filing their claims with the payer, just like they always do. But now I'm asking them to also send data, because I'm starting to pay based on analytics. So this is your physician quality reporting system or other type of quality reporting that goes beyond the claim. Those payers then take all that data, excuse me, and they have their advanced analytics engines. They may even blend it with other types of data like social determinants of health. And then they look at the contract and they say, okay, the type of contract that we have is a Category 3. I'm paying across this entire community for a shared patient based on an episode of care. You know, patients coming in for hip replacement. So I'm going to pay the hospital, all the providers involved during the hospital stay, and 90 days post-acute, one flat rate. And I'm going to adjust that rate based on whether they got readmitted or hospital-acquired infections or other types of quality measures, right? So now your payment is linked to the performance of other people you don't control. Or it could be the total cost of care for Adele. I'm going to give you Adele, and I'm going to give you all the money for Adele, and I'm going to look at the quality outcome and her health status. And if you don't have quality, I want some of my money back. That's essentially categories 3 and 4. So they're going to look at the claims associated with that contract arrangement, bundle them up, price them out, send them to that old Soviet mainframe, and then they're going to pay back to the community. So the new, and they should be sending data back to you as well. So the new types of technologies that are really entering this new economic model are basically data-oriented technologies. It's all about the data. And not only do you need to be paying attention to the individual patients that are coming in to see you, you need to know what populations, who you're affiliated with and what populations of patients you're responsible for. The payers are now trying to align with what's going on at the federal level and at the individual state level. They're trying to do this to ease the administrative burden on providers. And then the other piece of this equation is moving the data, making it liquid so that it can move very easily between providers and payers, which does not happen today, as we all know. So that's really where we're seeing policy head. Now, I don't know how many of you are pediatricians or, excuse me, don't see patients 65 and older, but this is a nationwide trend that's coming. Now, I live in Alabama. Our state motto is thank God for Mississippi. We are, you know, if the world's going to end, move to my state because it takes 20 years for anything to get here. How quickly this comes to your market will vary. But understand this is a survey, and I would encourage you to go to the Healthcare Payment Learning and Action Network. This is a public-private collaboration that was created by Secretary Burwell back in 2015, so it's not that old, but they measure every year what the penetration is across these categories of payment. And they just released their last measurement in October, last month. And this is what they're showing. For 77% of the covered lives in our country, that's how many people respond to these surveys, the number of payers that are using Category 1, the traditional types of payment, has decreased, and now only about 40% of them are strictly paying that way. When we look at incentive or bonus-based types of payment, again, we're starting to see a decrease, not a huge decrease from where, because it was on the rise, but it's about a quarter of them are paying through that type of payment arrangement. And when we look at these shared patient arrangements paid to the community, this is episodes of care, shared savings, which may or may not have risk bearing, and population-based payment, which is essentially capitation, that is on the rise. And it's up to, you know, closing in on 36%. So this doesn't really matter whether you see Medicare patients or you see other types of patients. This is something that you're going to see happen across all of your payers as time goes on. So short of retiring, this is something that you have to become familiar with. All right, so we've talked about the problem. Let's get into the response. The federal government right now, as I read policy, there are three aims, three things that they're trying to do. The first one, which was very much brought about by the Medicare Access and CHIP Reauthorization Act, was to get away from paying for a service and start purchasing value, which means they've got to define value. The second thing, and this one kind of tongue-in-cheek, kind of cracks me up, we want to make it easier on providers and lessen the abrasion of change. Okay, that's a great intent, but they're not usually very good at doing that. And then the third, as I said, was make the data interoperable, make it where it will easily move from the payer to the provider to the patient, or anywhere in between those three it needs to go. So if we look at these aims, they're trying to have data-driven payment, data simplification, and data liquidity. My common term there being data. So this tells me as I read this policy and this legislation, it is all about the data. Okay, that's great. This is what everybody sees. You are in the Hypopneuma Arapacamacra cures era. If you have been in the healthcare business for 15 or more years, you know what I'm talking about. It's the Hypopneuma Arapacamacra cures era. You hear bits and pieces. You don't know how it fits together. So I am here to explain the Hypopneuma Arapacamacra cures era to you in a single slide. Here we go. So when the Congress meets in 2-year congressional sessions, we are in in January, we will start the second year of the 116th U.S. congressional session. Congress makes our laws. Now understand that those lawmakers, some of them don't even have a college degree, but that's okay because they represent the people and we don't all have college degrees, right? But they're making our laws. Of all the laws that they propose in a 2-year session of Congress, only about 2% of them actually get sent to the president. That's why you see the word act. The Affordable Care Act, the Social Security Act. That means Congress has come together, agreed, and sent a bill to the White House for signature. Now, when the president signs it, it becomes the law. The details associated to that law, the laws don't happen very often. Congress coming together and agreeing, we all know that doesn't happen very often. But the policy, the regs that come out, the detail, that's where the devil is, right? That changes constantly. It can change with public opinion. It can change with leadership. It can change with lobbying. So when the president comes into the White House, and this is why this is such an important position, the president has a cabinet of close advisors. There are 15 of them. They're called secretaries, Secretary of Defense, Secretary of, State, Secretary of Health and Human Services, HHS. And under HHS, you have 12 agencies. You have CDC, FDA, CMS, HRSA, ARC, all these agencies that are under there. So our status quo right now is I pay a fee every time someone does something. So I'm going to take those providers and I'm going to put them on certified electronic health record technology. Well, that's meaningful use. And meaningful use said you're going to capture data, you're going to report data, and you're going to move data. So my common term there is it produces data. So I'm going to take that data and I'm going to put it in my big engine and I'm going to send it to other agencies under HHS like ARC or the CDC who does research, and they're going to look at that data and they're going to say, oh my gosh, check this out. When Dr. Jones does A, B, and C on a poorly controlled diabetic, we get a higher quality outcome at a lower cost. Oh, that's an evidence-based guideline. So I'm going to take that guideline and I'm going to put it in the hands of someone to educate providers. Your diabetics should be having A, B, and C done, and educate the patients that they need to be having that done. I'm also going to put measures out there to see whether that's happening and challenge those providers, not just to do it for the patients standing in front of them, but also for the patients that aren't coming in to make sure that there's care gaps are being closed. And then we're going to look across the ecosystem at who they share that patient with using advanced health information technology to see whether they're in sync with each other, and we will get performance data on the community and pay accordingly. This is the Hypopneuma Arapacamacra cures era. This is what has been going on for a long time. The system's been broken for a long time. So this accumulation of laws are the attempts to make this happen. If we overlay the laws, MIPA is a Bush-era piece of legislation that that started e-prescribing. I don't know if you remember when that became mandatory for Medicare, and now it's the way we write scripts. It also required CMS to start producing the Quality Resource and Use Report. And if you don't know what that is, I would write it down. This is something that you can download on your providers to see how they're measuring up on severity of illness and cost. It's something that is available to you, and you need to be looking at what your data says. Then you have the American Recovery and Reinvestment Act, which was enacted under President Obama. It was 1,400 pages of law, things they would call cash for clunkers. You know, this is a stimulus act. Well, in that 1,400 pages is 60 pages called high tech. And high tech is what created meaningful use. And we all remember having to adopt our electronic health record systems. Then you have TRICA. TRICA is a Bush-era piece of legislation that said claims data is not enough. I want clinical data. So I'm going to ask providers to voluntarily send their clinical data under the Physician Quality Reporting Initiative. Well, that didn't go so hot, but so it became a permanent system for Medicare. This is now the quality reporting track for MIPS. So this is permanent. Then you have the Patient Protection and Affordable Care Act, which talks about getting value out of healthcare 219 times. And then once I define that value, I'm going to pay for value under the Medicare Access and CHIP Reauthorization Act, either under the merit-based incentive payment system or for a shared patient through a risk-bearing alternative payment model. And I actually sit on the board of directors for WEDI, which is a federal advisory work group. And guess what they're talking about? ICD-11. That's, the law hasn't changed. HIPAA is the law. That was, established in '96. This is a policy change that says under HIPAA, that transaction code set needs to move to ICD-10, ICD-11. So you're up for that. And then in 2016, we got the 21st Century Cures Act, which is requiring interoperability. And this is the game changer, not just for providers, but of payers. And that was the big difference in this particular law. So this is what's been going on. This is the HIPAA, MIPA, TRICA, ARPA, PACA, Cures era. This is what's happening in your world. Excuse me, and what they're attempting to do. So hopefully that makes it, clear as mud for you. But this is, these are the two areas that we need to be aware of. We need to understand how the payers are measuring us and look at how we're managing our active patients to those standards. We also need to know what the providers with whom we share patients, the hospital, the specialists, the primary cares, how they're measuring up. Because at the end of the day, how you get paid is not just going to be dependent on what you do. It's also going to include the cardiologist you refer to, the hospital that you use. And if things are not happening there, if they're not measuring up great, you're going to get dinged for it. So that is what you're under right now. Now let's look at some of the Medicare trends. So Medicare, we have an aging demographic in this country. I'm part of the baby boomer generation. We're a real indulgent lot. So we're paying for our Woodstock and, sex, drugs, rock and roll. We're paying for all that now. There's about 57 Americans that are on a Medicare type of program. But what they're seeing is a growing enrollment in privatized Medicare. So this is your Medicare, your Blue Advantage plan, your Humana plan, your United Healthcare plan. So they're expecting this to, it's tripled since 2004, but they're expecting this to continue to grow to about 50%. These are your mega trends. So what plans do is they bid on this and then they compete just like, your commercial carriers compete. But if they get that their HEDIS data, which right now plans are capitated and they're measured for their quality, and they call that star ratings. If a plan on a 5-star scale gets 4 stars or greater on their HEDIS data, they get this bonus payment. And if that plan has more money, they have more money to pay you. So this is where, there's a linkage between how they get paid and how you get paid. If you look at United Healthcare, Humana, and the Blue affiliates, that's going to represent nearly 60% of all your Medicare Advantage enrollment. Now, Parts A and B, the government controls, and that's what they're doing under MACRA. But Part C, that is privatized. And the contract relationship that you have with Blue Advantage or Humana or whoever, that is a contractual arrangement between you and that payer that CMS doesn't have control over. But they are strongly encouraging these MA plans to align with what they're doing with traditional Medicare. And so star ratings has become a real financial and consumer market differentiator. I don't want to sign up with a 3-star plan. I want to go to a 5-star plan. That's what's happening there. On the Medicaid side, Medicaid is, again, growing. It's closing in on 80 million Americans. We only have 325, roughly, Americans in our country. The interesting thing to me is roughly, 57 to 60 cents of every single dollar that you get on Medicare reimbursement is coming from the federal government. So even though states contribute to it, and it's a state legislature that controls this, the lion's share of that money is typically coming from the federal government. Now, some of the mega trends that are going on in Medicaid, there are only 11 states in the entire union, even the District of Columbia, which is not a state. Every one of them except 11 states are privatizing their Medicaid. Their Medicaid agencies moving in that direction. And they call these entities managed care organizations. So you've probably seen this in your state. I know, I talked to Iowa, I know they've had some churn in this area, but that's United Healthcare or Centene or Amerigroup. These are the types of payers that get into this business. There are actually close to 300 MCOs, managed care organizations, across the nation. And if we look collectively at the number of enrollees they have, they're basically 3/4 of all your Medicaid enrollees are under these types of plans. The other thing is work requirements. These are waivers are now being approved by CMS. Now, there are 14 states involved in this. 3 of them were set aside by courts. That was in Arkansas, Kentucky, and New Hampshire. And that was simply because the work requirements, the number of hours they said was not fair. So they set those aside, but you can guess they'll probably re-up. Only 1 has been implemented so far, and that's in Indiana. You have 4 that have been approved and 9 that are pending, including in my home state. They're seeking work requirements. This is a great philosophy. If you're able-bodied and you're receiving government welfare, or government's paying for your, health care, you should work. That's a great concept. But here's the problem for you as a provider is we already have a lot of eligibility churn in this population where they're eligible for Medicaid this month, but not next month. If you add another requirement and it's not properly operationalized, it's going to make that churn on your Medicaid patients much, much higher. 23 states are mandating value-based payments, and some of them, like Ohio, they're being very specific on what that payment model needs to look like. So again, we've got the federal government with 57 million Americans and Medicaid with 80 million Americans moving into value-based payment. It's not hard to guess that your other payers will move in that direction as well. Now, when it comes to a health plan and their program framework, what the purchaser of these services is demanding is a better, smarter, healthier system. So a purchaser could be a government entity. I'm Blue Cross, and I contract with CMS to offer a Blue Advantage plan, or a state government. It could be an employer. It could be an individual that's purchasing insurance on the insurance marketplace, but they want lower costs, they want better care, and they want better health. Now, that's known as the triple aim. Now, this other one down here, I've got this little provider down here with a smile on his face. This is the quadruple aim. It's a happy provider. They're enjoying their work again. I've got that as a dotted line because that's a lofty goal. I think it'd be great if we can get there, but I think that's kind of a lofty goal. So when we look at this, what it takes from a framework perspective, this is what health plans have to do in order to try to get there on what their purchasers are asking for. They have to look at what the benefit structure looks like. What are they going to cover? What are they not going to cover? You know, this gets into your formularies and things like that, and there's only so much money. The other thing that they're held to a very strict standard on having an adequate network. If I'm selling insurance in, you know, Podunk County, USA, I better have the providers to take care of the patients in my network. Otherwise, I can't do that. So there are state and federal requirements on them having enough primary care, enough specialists to support the business that they're selling. They also have to worry about how they're paying the providers. And this is where they're trying to get into value-based payment. And then they get paid based on their own quality measure as a health plan. We've already established that. So that's your star ratings or some other type of quality payment program that will be in place if they're doing government-sponsored or even employer-sponsored type of coverage. So that's the framework. Well, in order for them to have that happen, this is the infrastructure that your health plans need in order to operate. Now, this is huge, and all of this has to work in sync, and this is why it takes more than a village to run a health plan. Excuse me. So when you think about the systems that you have in your organization and how sometimes if something's not working right with something else, the chaos it causes, you have a practice management system, an electronic health record system, you may have a lab information system. Look at this beast. I mean, this is what your health plans have to orchestrate. It's just phenomenal. And so that's pulling the curtain back a little bit and letting you know what all is going on from just an infrastructure, not to mention people perspective. They've got to have domain experts in all of these areas. So it's pretty Herculean. All right, so we've talked about the problem. We've talked about the response. Now what we're going to do is talk about your claims and your payments. And this is where you become very aware, if you're on this call, how integral your role is in this whole equation. I don't know if you knew it, but you basically control the world. The most ubiquitous data that we have in healthcare today is claims data. Everybody has claims data. It's everywhere. Payers have it, you have it, hospitals have it, everybody has it. So let's talk a little bit about that type of data. And what I'm going to do is I'm going to, I actually worked, when I worked on the payer side, the last payer I worked for was Blue Cross Blue Shield of Montana. And I was the person that set the rates of reimbursement, so I was extremely popular, as you can imagine. But I'm very familiar with this process. This was something that I had to live through. So back, when we got, in 1965, when we got our socialized types of coverages, and before that time, when third-party payments came into the equation, all those payers were paying full charge. You bill me, and I'll pay you. So whatever you charged was what they paid. Well, just like everybody has their trade groups, and here y'all are part of MGMA, your health plans have trade groups too. And some of these groups started to amass the claims data that was coming out in these big databases. They're called HIA, MDR, and they're still used today to just take a look at coordinated benefits or out-of-network providers, things like that. So they came up in 1974 with this concept of setting a fee schedule. by establishing a usual, customary, and reasonable rate. And what they would do, and I'm going to take you to Nashville just to be a little agnostic here, and we're going to look at a level 3 established patient visit. And what the payer would do is they'd say, I want to look at the highest charge in that range of zip codes in Nashville, down to about the 50th percentile. And I'm going to slap those charge rates up against, you know, that range. And I'm going to draw a line in the sand at about 80 or 85%. And I'm going to call that the usual, customary, and reasonable rate for a level 3 established patient office visit in Nashville. And that means in Nashville, 15% of my providers are charging more than that. 85% are charging that amount or less. So that's a fair rate, right? Well, here's the problem with setting your fee schedule that way. First of all, it's charge driven. So if you knew this is how your fee schedules were derived and you want to see a pay raise, what do? You just raise your charges, right? And charges are not scientifically derived. You know, I can tell you I'm selling, you know, my house for a rate that's just astronomical. That doesn't, I can put whatever I want to charge for. It doesn't mean it's a fair scientific arrival at a rate, right? So just like we see things happen, CMS is a payer. They're just a governmental payer, which means they get to make the rules. They're no different than Blue Cross or Cigna or Aetna or United Healthcare, any of them. They all have common goals, but CMS gets to make the rules. They're the king, right? So they get to make the rules. So anytime CMS moves in a certain direction, you can expect the entire industry to go in that direction from a payer perspective. And what happened was they were paying, you know, they started setting up the fee schedule in the mid-70s using, you know, these databases, a percent of charges. And then they said, we got to come up with a more scientific way to come up with our fee schedule. So they hired the Secretary of HHS, got in touch with Harvard in the mid-'80s. I was actually in healthcare at this time, telling my age a little bit. And I don't know if you remember paper claims and stickers and shoving them in envelopes and all of that. But the whole idea here was coming up with a scientific way to derive your fee schedule. So in '88, Harvard came back and presented their first phase of a scientific way called RBRVS. That then, under the first President Bush in '89, became law of the land. You see that term act, and what did we say that means? That means it's a federal law. Congress has acted. It's been signed into law, and short of literally an act of Congress, this is what happens. And it said Medicare is going to go to this type of fee schedule. And by 1992, RBRVS became the way that the Medicare fee schedule was derived. And I can tell you that all of your payers are using some method that relates to this. It's very, very similar. So the way that RBRVS works is it sets up what's called a relative value unit based on a 3-part weighted formula. The first thing they look at is how hard does that provider have to work to deliver that service? You know, what's the skill, the time, the effort, the stress? Then I'm going to look at associated expenses. So do they have to use a supply, you know, administer a drug, use some kind of a device like an EKG or something like that? There's a cost associated with that. And then the third thing I'm going to look at is what is the risk associated with that service. So if I were to compare an office visit to brain surgery or heart surgery, which one do you think is going to have a higher RVU? Obviously, the surgery, right? And then what they do today, and there's some people who say they shouldn't do this, is they geographically adjust those rates using a GPCI factor. The concept here is it costs more to deliver, the overhead costs more in New York City than it does in Des Moines, Iowa. So that's the argument there. So today this is all geographically adjusted. Now what happens is every year, and I read this rule, this is policy, so this is coming out of HHS. This law has not changed. But the fee schedule changes every year. And every year they propose a rule of what it's going to be for the next year. That usually comes out roughly late June, early July. They take comments from the public, and then they issue a final regulation. In fact, the one for 2020 just came out November 1st. It's over 2,000 pages. And in there, they establish the elements for like the GPCI, your RVUs, and they set forth the conversion factors, so how much each relative value unit is worth. So when we look at what was going on in 2019, your conversion factor was just over $36. And what did I tell you about MACRA? That they're freezing the fee schedule at these rates. There will be no more increases. Look at this rate. Essentially, no increase. If you want to make more than Medicare fee schedule, you have to measure up with your data. Otherwise, you are going to be on declining revenues. And this is the future. So if we look at this from a calculation, this is the equation. I take each one of my RVU units, geographically adjust them, total them up, multiply times the conversion factor, and that gives me my fee schedule rate. So if I take that Nashville level 3 established office visit and I multiply it out, I get my RVUs, multiply times my 2020 conversion factor. In Nashville next year for a level 3 office visit, they will get $68.78. That is how Medicare calculates the fee schedule. Some version of this is how most of your payers are calculating their fee schedule. So there you go. All solved, right? So here's what's happening now with Medicare. And this is where so we know that all my other payers have kind of followed suit and done that. So here's what's happening now with Medicare under MACRA. So we already said I get this relative value unit, I multiply times the conversion factor, which note that conversion factor is not going to increase anymore because the law says it can't. Now I'm also going to factor that against a MIPS number. That MIPS number is going to come from data under 3 categories. This is your composite performance score. So they're going to look at your quality of care. This is that PQRS. It's permanent now. We're looking at quality. They're going to look at cost. Now, where do you think they're getting their cost data from? They're getting it from claims, because what your claims is actually a reporting vehicle. When you file claims, you are reporting data to the people who pay you. Yes, this is how you get paid, but think of it as a reporting mechanism. And then the other category is performance improvement. Now, if I'm primary care and I'm a medical home, I may get full accounting for this. But it's also things like extended office hours, timely return phone calls. So that's what this category is. And then this third one is interoperability, promoting interoperability, which was the former meaningful use program. So you will be asked to use and continue to use and expand your use of technology. All of these categories sum up to create a performance, a CPS, a composite performance score. And based on what that score is, that gets factored against your fee schedule, and then you get your payment. This is the future. So it's analytic driven. This is all data right here. And all that data is going to get multiplied times how we've been calculating a fee schedule to come up with your payment. That's MIPS. Now, if I'm doing advanced alternative payment models, then I'm also doing this as a community. I'm looking at the cost of care, not just for what you do, but what everybody that's touched that patient has done. The total cost of care for the year, or by episode of care, some function like that. So that's the difference in the economic model. So we've established it's all about the data. So let's back up and let's talk about data. There are 4 ways that you can enter data into technology. You can scan it in. That's going to be like a picture. So there's no data associated with that. I can dictate or type. Now we have what's called natural language processing, and they're trying to start mapping that to structured data, but essentially that's just a string of characters to a computer. You have user-defined structured data. So this would be like appointment types, where I say, these are the types of appointments we have, and then I can run a report on all how many consults Dr. Smith had, last month. But the holy grail is this object-oriented codified data. And on claims, we have that in spades. There's actually 400 data points on a claim. You have demographic information, and then you have the machine-readable, codified answer to two questions. What did you do? I answer that with a procedure code. Why'd you do it? I answer that with an ICD-10 code. And if I put an E11.8 on any claim, every system in the United States knows that that is diabetes. And that tells me something as a payer. A diabetic's going to cost me more money than a non-diabetic, right? So when we think of the code structure of an ICD-10, your first three are category, then you get into category, anatomic site, severity, and then I can get into more specificity. The sweet spot is all of these characters that come after the decimal point, because that's where I can tell my payer the disease etiology, body part, illness severity, or additional specificity. So payers are managing risk. So what does that mean? Okay, so when we think about risk, payers are in this business. Now, as we look at these models and the categories advanced, they're looking to shift that risk to the providers. But that huge infrastructure I showed you, that's what that is for. It's because they've got to know that they're taking in enough dollars to cover the dollars they've got to pay out. So the way that they do that is when patients enroll, and we all know when patients come into your office, they all have health baggage, right? So some of them, and this is the risk, some of them are well controlled. They're heart healthy, they exercise, they don't smoke, they eat their veggies and fruits, they don't have, horrible genetics. They're just not going to cost me a lot of money. They're pretty healthy people. The other side of the equation is my exposure. So this could be people who, drink heavily, they hate sweating, so they never exercise. They are terrible smokers, 2 packs a day, or hey, even better, let's get into that cig of weed. They eat nothing but carbs, which is my personal favorite, and they've been hit with the genetic crap stick. They've got, markers, the BRCA gene, and they've got colorectal cancer markers and all kinds of things. Now, my choice, whether I am a provider ecosystem that's taking risk or I'm a payer, is I can either accept the risk, the people on this left side of this chart over here, I can just say, okay, I'm just going to have to pay the claims on these guys, or I can take actions to try to move some of them over here. Now, the ones that are way, way, way over here, so I've got my yippee side, yippee, they're all healthy, to my yikes side. I need to know when I sign that person up, where do they fall? Are they more on this side of the equation or more on this side of the equation? And if I've got somebody that's way over here, they go to jail and they don't care, about their lifestyle, the chances I'm going to get them to quit smoking are zilch. It's just not going to happen. But the ones that are kind of sitting over here, if I could just move them a little bit more over here, I start to make money. And we're not talking about those fee schedule, pennies or few dollars. I'm talking millions of dollars when we're talking populations. So this is what we're trying to get to with these new economic models. Now, how you code patients coming in today for upper respiratory infection, oh yeah, they're diabetic. So I slapped that E11.8 on that claim, which I've just now told my payer that I have a healthy diabetic. So that says something to them. They know that they are not way over on the healthy side. They're somewhere in the middle, but they're well controlled. So they're going to cost me around $1,400. If in fact I've got a sick diabetic that's, an E11.21, and I'm not communicating that to my payer, look at the difference in the cost. First of all, then they're not communicating that to CMS, who gives them a capitated rate for that patient, which means they don't have enough money to pay you when you need to do more things because you have a sick diabetic. Or if I'm handing you this patient and you've told me this is the patient you have, when in fact this is the patient you have, you're not going to be adequately paid to take care of that patient. So the data is everything. And the easiest place to start is with your claims. And again, if you don't take anything else away today, take this away. When you submit claims, you are reporting data to the people who pay you. Now, coding with specificity gets very, very difficult if you have a problem with timely and complete documentation. So one of the things I encourage people to do is to start with clinical documentation improvement. So if this is all the provider has documented, they have a broken forearm, this is all you can code. If they say, well, where on the forearm? Lower end of the radius. Which arm? It's the right arm. What kind of fracture? It's a torus fracture. Where are they in the healing process? Well, it's a subsequent encounter with delayed healing. Look how much information I can then communicate to the payer with one code. Great place to start. And you have control over this. Now, I know I'm getting to the top of the hour, so bear with me. I'm going to try to get through this pretty quickly. When we think about other industries, a lot of them are using data. And if you go to Target or any of these retail centers, they use their data extensively. The story is based on a report that came out in the New York Times back in 2012, so there's no telling what they're doing with data today. But when you came in 2012 to Target, and you used your debit card or a credit card or a check, they would set up a guest ID and start amassing data on you. They would look at what you were buying, your demographics. Can I email you your receipt so they know where you lived? But they took that data and they slapped it up against their baby registries, and they saw a trend in the data. They saw when a woman bought certain things, like unscented lotion or zinc and magnesium, there was a high probability she was pregnant. Well, a dad in Minnesota got very upset when his teenage daughter started getting new mommy ads from Target. He went down to the local Target, grabbed that general manager, and pitched a bloody blue fit in that store. And 3 months later, called back and apologized because guess what? She was pregnant. And Target was able to predict the pregnancy of a woman based on shopping data back in 2012 with 87% accuracy. Now imagine what we could do if we used healthcare data in predicting illness and controlling things. And that's exactly what we're trying to do here, is take the data. Yes, we're using it for payment, but use it to proactively manage the care of patient instead of reacting to what needs to happen. Proactively manage care. So if I get my enrolled or attributed population, first thing I need to know is what is their health status? Are they, in my controlled part of the population or my exposed part of the population? Then I'm going to stratify that risk. There's going to be some people in that population who will never use the health plan. Or use your clinic. There's going to be some that are moderate risk and some that are high risk. And what I want to do is intervene. There's 5% of the population will spend 50% of the dollars. So I want to intervene and try to pull them back to a healthier status. And they'll cost me less money. So from a data perspective, you need to know who those people are. You need to know what their health status is, where they stratify, low, moderate, or high risk, and then figure out how you're going to intervene. That is population health management. So just a cautionary note on care coordination, because this requires us to be in sync with people outside of the four walls of our clinic. I'm going to tell you a little story. Once upon a time, there were 4 imaginary characters. Everybody, somebody, anybody, and nobody, and they all worked for Dr. Seuss. Well, one day there was an important job to be done, and everybody was sure that somebody would do it. Well, It turns out that anybody could have done it, but nobody did it. And somebody got angry about it because it was everybody's job, and everybody thought anybody would do it, but nobody realized that everybody wouldn't do it. And it ended up that everybody blamed somebody when nobody did what anybody could have done. This is what we have going on in our operation. And if this is happening in your practice and the practice that you're referring to, is it any wonder that the information doesn't follow the patient? I mean, this is a great place to start when we think about that shared patient. All right, so what payers do is they have an analytics engine. They have data sources that are going in there, some from the members based on what they're enrolling and the benefits. They've got data on you, what they're paying you, where you're located, what kind of specialties you treat. And then they've got all their plan operations data. So they put that into these engines that they have. And then they use some type of analytic tool. So this is an example of a tool called ACGs that was developed by Johns Hopkins. So they will run all their patients through here. And these are my non-users. These are people who, you know, they'll never use the health plan. As I move more towards here, if I've got somebody that has 10 chronic conditions, they're a train wreck. They're going to be a complex, high utilizer, cost me lots of money. I need to know who those people are. So this is where I'm looking at where they are on my, ooh, yippee, I got a low-cost patient versus, yikes, they're going to cost me a lot of money. And we know pregnant women are going to cost you something, as well as, you know, we've got to do the well child and stuff like that. So we know there's going to be costs with women and children. So they run the population through there, and then they're able to queue up using predictive analytics a profile on the patient. So here's an example. They would say, well, let's look at the condition markers. I know they're being treated based on their claims data. So this is how they use your claims data. I know they're being treated for hypertension, and it looks like they have a diagnosis for schizophrenia. It looks like they're on a medication that's typically prescribed for treatment of depression. Well, let's look at their risk and utilization. Their current relative risk score is below a 10, but the system is predicting that the wheels are about to come off. They're going to go up to almost a 40. Well, why is that? Well, they've been to the emergency room 6 times in the past 6 months, and they've got 6 different doctors, which I'm sure those doctors don't know the other one's seeing them. Do they have a primary care? Yeah, it's Dr. Carson. Let's get in touch with Dr. Carson before the wheels come off the car here, you know, and let's intervene. This is how they try to use this information. But imagine if this were in your hands, if they were sharing this information back with you. And all of this that I'm showing you is from claims data. So how you code and how accurate your information is means everything. So that is all I have. I know I'm 5 minutes over my time, but I'm going to encourage you to think a little differently than you did before you joined this webinar, and dream big. There's a lot of opportunity out there. Thank you for joining us, and I'm going to turn it back over to Jean. I don't know where we need to go from here.
Thank you very much, Adele, and for everybody attending today. I don't see that any questions have come into the chat room, but again, you are welcome to submit questions via the webinar survey. And I will, the states will be sending out future webinar emails. I think the next one is December 10th, so keep an eye out for that in your email. And there's just one comment that says, excellent presentation, thank you.
You're so welcome.
Not seeing any questions, so we'll wait just another minute to see if there's any questions, if people, but it looks like everybody's running back to work.
Yeah, I hear that. So,
and to Kathy's question, yes, I can send out a certificate of attendance. So I'll make a note of that and get that. Adele, there is one question. What is the one biggest impact a biller can make to lower their denials?
To lower their denials, I would get with your payer. If you find that those denials are trending with a certain payer, I would call their provider relations department and ask them that question. because it could be in the way that you're coding the claim. There could be a better code that you could use, or maybe a modifier or something like that. So I would look and see if that's trending to a specific payer.
Thank you, Adele. Thank you for that, Adele. And Dawn, I do see your email about a certificate as well. Give it just another minute here, if you've got a minute, Adele, and see if there's any other questions that come in. Okay, at this time, I think I will go ahead and end the recording and end the webinar. And thank you again very much. Have a wonderful Thanksgiving.
Yes, happy Thanksgiving. Bye-bye.